This is, oh, it's reversed.
Forward.
It's forward and back.
Reverse.
Okay. So first let me thank Henry and Yung Il Kim. And he's not here, Jaskiro. Huh? He can't hear you. Okay. Sorry, I have a soft voice. I've been married for 25 years, so I learned to speak very slowly and softly in front of a lot of people. So again, I have to thank our host and the Atomic Energy Agency for their support. Are they streaming this now? They're streaming me.
If you agree.
Yeah, that's
yes,
what they're streaming. So you can even say jokes, right? Because everybody's very sleepy. I will tell you just one joke for today. It was from our priest when I went to Mass. They were giving us a sermon about marriage. So it was Easter, and the church was full of people because the cardinal was giving Mass. They're all very patient, and then suddenly in the middle of Mass, Satan shows up. And then everybody started screaming. They ran out of the church, except for one old guy in front. So Satan walks up to him and he said, "Do you know who I am?" And the old guy looks and he says, "I know who you are." "Well, aren't you afraid of me?" Oh, he said, "No, I've been married to your sister for 49 years. I'm sorry, I know you're very sleepy, that's why I thought it would be good if we talk about funny things. First, let me tell you about MD Anderson. MD Anderson is a very socialistic hospital. We're like communists. We share everything. It's like a single practice. Everything is multidisciplinary. We don't have a patient. We share all of the patients. All of the money, because it's always about the money, all of the money earned by imaging is put in the pot. Surgery puts it in the pot. The other two areas which make money, laboratory and pharmacy, puts it in the pot. And the last one is radiation oncology. Okay? And then we share it with everybody. All of the patients are reviewed. We call it a multidisciplinary team. And nuclear medicine is part of that team. What I'd like for the people who are just beginning PET-CT to remember is you have to be very careful and very judicious with your use of this imaging modality because our physicians act on it. They decide and they change management or switch management based on your findings. So that's the first thing I'd like to say. And the problem we share, which is for us is cancer, is a global problem. It is found worldwide. Although it is found worldwide, the economically developing part of the world accounts for a greater number of deaths and greater number of cases, and it will be greater in the developing world. So we have to be cognizant that the job we have at hand is not only big, it tends to grow over time. This is something else I'd like to emphasize, is that lung cancer is the most common problem for men globally. Prostate cancer is still the most common one for men in developing countries, and breast is the most common type among women. However, in places like the US, the lung cancer is surpassing breast cancer in developing countries as a cause of death. So there are things we can do which are very straightforward. The one I think, which was alluded to by Professor Baum, Henry said, is smoking. It can affect all of the non-communicable diseases. For us in MD Anderson, if you are going to join us as a member of the faculty or as a technologist, physicist, we take a blood sample. We have to detect tobacco products in your blood. If it is detected, you are given provisional employment and we will enroll you in tobacco cessation program for 3 months. And when we retest you, if it's still positive, you will no longer be an employee of MD Anderson. Everybody is requested. Everybody has availability of vaccination, uh, including vaccination for HPV. 70% oropharyngeal cancers are HPV related. All the children, we ask that all the children of all their employees get vaccinated. These are very, very cost-effective things. It is far better than PET imaging, all of the therapies we do to get vaccination, stop smoking, stop sun exposure, especially for places like Australia, New Zealand. We have enacted laws for Texas and want to apply to the whole US that we ban young people from being allowed to have tanning salons. Unlike me, many of the Americans are very white, but they like to look like us. So I don't know why, but that is something which is very common. So tanning salons. So again, vaccination, behavioral change, which is essentially safe sex, right? The use of barrier systems are very important. I know this clash with religion sometimes, clash with practice, but in the end, cancer does not distinguish sex, religion, it just affects everybody. None of us in this room has not been affected by cancer because we know somebody who has been affected. What we'll discuss is lymphoma today. It's pretty common, and I'll skip this because you have it in your slide set. But it's just to reemphasize, at least in the U.S., we have the greatest number of cases. For us, we have standardized staging and response evaluation. I failed to make a copy of it, but I had a direct request from our uh, current physician-in-chief, who's a radiation oncologist, Thomas Buchholz, requesting many years ago, actually, when the onset of the IHP and the Deauville criteria was done, to standardize our reporting. The new chief, Steve Hahn, who will replace Thomas Buchholz, has asked that we do what we'll review today, the Lugano classification. If it's standardized and the response evaluation is fairly standardized for clinical patients as well as trial patients, it makes our job more easy. What I ask you to know is to know patterns of spread, because for people who think PET-CT is easy, they probably don't do it well. It's very difficult. So many slices to look at, so many correlations. You have to correlate the CT. You have to have equal, shall we say, emphasis and expertise on both sides of CT and PET. For nuclear medicine physicians, I emphasize the CT portion. For radiology, I emphasize the PET portion. For both, it would be the history. For members of the audience who actually read with us, like Benjapa, they realize we spend 80% of our time reading the history. The interpretation becomes far more efficient and easier if you know what's going on with the patient. So you have to know the patterns of spread is where to look. Sometimes this hybrid imaging can be done as part of the biopsy procedure if they are unsure of the biopsy, because in the end, we cannot treat based on imaging. We treat based on the pathology. Lymphoma is essentially a liquid tumor, so the prescription of the treatment depends on the molecular profile. Contrast-enhanced CT is very important. It is, we don't replace it, but it's part and parcel. But the standard now is actually FDG. And standardized reporting, not staging, but reporting. We have templates. We have, when it's like we use PowerScribe, and I say macro PET or macro FDG PET, it populates everything. It forces us to read the neck well, read the brain well, read the chest well, because partly for me as an administrator is make sure we get paid. In the US, if you did a scan from the orbits to the thigh, you didn't mention anything about the neck, about the heart, they might not pay you because you said, well, it's normal. How do we know it's normal? You didn't say anything about the heart, the pericardium. What about the lungs? What about the pleura? What about the thyroid? What about this? What about that? And by looking at it, one gets trained to look out for these things. There are many staging systems. The original one, which you might remember, would be the Ann Arbor staging system. Stage 1 to 4, it's lymph nodes. Stage 1 would be localized lymph nodes. Stage 2, contiguous nodes, one side of the diaphragm. Both sides of the diaphragm, stage 3. And then stage 4, you have extranodal disease. It's still partly used. The international working group was response based on CT to measure that. The IHP was based on PET-CT, but the one we'll discuss is what is now considered the standard. It is developed to simplify and unify staging and response assessment as well as reporting. It's actually simpler. Uh, what you can understand from here, Ann Arbor, IWG, the IHP was done in Deauville. The medical oncologists are better at choosing their venue for meetings. These are like the nicest resorts in the world. Deauville is in France, and you know, it's that's what we say. So it's strange if my lecture to you, the handouts would be on the clinical side, because I think these 4 or 5 cases are the most common ones. Hodgkin's disease. How do I characterize Hodgkin's disease? Sometimes they present in younger patients or older patients. They're the 10% of all lymphomas are Hodgkin's, and usually they're nodal. Sometimes they think patients have lung cancer, they have massive mediastinal adenopathy, but you don't find anything in the lungs. You biopsy, it's Hodgkin's disease. Often they would be mediastinum or neck. They could be presenting that way, and they have very high FDG uptake. So what I'm saying is prevalence, clinical profile, as well as spread, FDG avidity. What is the treatment? ABVD, adriamycin, bleomycin, vincristine, and steroids, plus or minus radiotherapy. If they have advanced disease, they have BCOP. Why? We include this as part of the reporting. It tells the referring physician we're aware of what treatment's been given. Why? Because the treatment, ABVD, can sometimes cause pulmonary toxicity. BCOP can, there are certain side effects from these drugs which you need to be aware of as part of the interpretation. What is the aim for this treatment? It's actually cure. It is a curable disease. That's why the primary consideration and what the effort is towards now is using PET as a method to limit the amount of therapy to minimize long-term toxicity. What do I mean by that? You give chemotherapy, maybe shorter chemotherapy if their PET the response is very good. So that's what happens. Let me just figure out. Oh, it's moving. Diffuse But if they come up front, the best thing to do is one-stop shop. You administer oral and then IV contrast during the acquisition of the study. So it's one, and then you can actually taper the dose. You can make the dose of the radiation lower, okay? You have to understand that the newer detectors are improving. I will digress for a few minutes because one of the best things about PET MR, when it developed, it forced the development of the digital detectors for the PET study. The older detectors, the current state of the art would be the photomultiplier tubes, right? And they have photo. We're taking shipment of several of these scanners, which are now solid state. They're much thinner. Why? They're just like, forgive my analogy because I like candies. They look like Hershey bars. They're very flat, very long, large field of view, triple the sensitivity for time of flight. So instead of giving 8 millicuries of FDG, you can give 2. Or you can give the 8 and acquire in 1/3 the time. This were necessary to allow the detectors to be inserted into the magnetic field and will not interfere with the coils. So this is probably the direction we're going to in the future because they'll be faster, quicker, and higher sensitivity and accuracy. That's why maybe in a few years, all of the scans I'll show you will be much, much nicer and crisper. So you want the lowest dose for the least time and in the most efficient manner. We have a rule we try, last year we did over 20,000 FDG diagnostic PET studies, which is just a small number compared to the number of CT scans we do. We do like 700-800 CT scans a day. PET studies, we do about 100 a day. So how do you read them, right? We read them based on the next appointment. No scan should last over 24 hours, so we try to read them within a specified period. So why do we do that? The patient has a very bad diagnosis. No amount of money can alleviate the anxiety of having a study done, which will tell them, do they have cancer? Or if they have cancer and been treated, is it the same, better, or worse? So we try to be efficient. My message is don't let them sit around. Read them as fast as you can and as efficiently but accurately. So how do we read these studies? This is an important one because with the lymph nodes, the physicians can feel them because they will tell you where to scan. If they're FDG avid, if they have increased FDG uptake, they're positive. They're non-FDG avid, you use contrast-enhanced CT. For the spleen, again, diffuse uptake, hotter than the liver. It could be focal or multiple sites. These are positive. If it's non-avid, you look at the coronal view. The coronal view greater than 13 centimeters is enlargement of the spleen, is considered abnormal. The liver, diffuse uptake, if it's a mass, FDG avid. If it's non-avid, you look on the contrast-enhanced CT study, the nodules. For the brain, usually MRI is the standard, but if they have primary CNS lymphoma, they could be very hot. You still need CSF because we can see single cells, so they need to tap, okay? Other areas, it's site-dependent, and you may need biopsy, particularly for the GI tract or the skin. The skin is very perplexing now because we give what we call immunotherapy, CTLA4, a programmed cell death 1 therapy, and it causes some granulomas on the skin, which could be necrotizing or non-necrotizing, could cause, I'll show you examples of that later in the week. Can you distinguish hot from cold? Hot or cold lymphoma would be aggressive or non-aggressive. Heiko published this. Heiko is one of the faculty at MSKCC, and he actually republished this a year ago in a larger number of patients. So if they're hot, they tend to be more aggressive. that is not any different from what we know. If you look at thyroid cancers, most well-differentiated are not very hot, but one of the hottest tumors you'll see is a anaplastic tumor. And for lymphomas, it's the same thing. You can always distinguish indolent, more or less, not always, but most of the time, from the aggressive. The higher the activity, the more aggressive they are. This is an old case. I always keep coming back to it because I can't find any better cases. You can have a lymphoma, comes in on the outside. We still repeat the PET scan even though they said the diagnosis is low grade because the patient kind of doesn't fit. You have bulky adenopathy, mesenteric adenopathy, bilateral, pelvic, bulky adenopathy. And on the FDG study, you can see it's very hot, but there are two sets. So the other thing you have to remember is you have to window it properly, make them hot, make them cold, because you may have two sets. It's like eating steak. You go to the steakhouse, you want medium rare, well done, or rare. When you read the PET scan, you do it the same way, medium rare, well done, or rare. You have to play with, you don't read it when it comes up. You have to do something. You have to pretend it's very difficult, you know. So you have to make it dark, so the areas of low activity you can see. You can make it light, so very hot areas like this, you can see the second population of cells. You flip you can see here on the contrast, even with contrast, contrast do squat. It cannot distinguish the more aggressive from the less aggressive. It just shows you enhancement, right? So you flip them over, you biopsy, and it shows you that the core biopsy, again, there's a technique, it has to be core, will show you diffuse large B-cell lymphoma. And this is a mix with low-grade lymphoma because the aspirate is still low-grade because it's more superficial. So when you look at it after 6 weeks of therapy, the ability to distinguish allows you to tailor the therapy, and tailor the biopsy and then the therapy. And the treatment is very specific for the diffuse large B-cell lymphoma, but you can still see that it was able to distinguish and show response to these patients. So you need to use response. It's a visual scale. It's a 5-point scale. And again, you still use CT for low or variable FDG activity. CT, you use bidimensional and you total them. But that's not our focus. Our focus would be on the PET side. The PET side is usually, it goes away. Complete metabolic response, no matter how big that mass is, it sometimes could be discordant, but if the activity goes out, it's complete metabolic response, okay? If it's a partial response, it's on the CT side. It has to be a reduction of representative nodal disease or extranodal lesions in at least 6 sites, okay? This is just to remind you, you have to do it before therapy. If you just can't wait and you do the scan a day after starting CHOP chemotherapy, it's gone. You don't have a baseline. That's what it is. This is just to show you, you can see a well-done contrast-enhanced study. You can see the vessels very well. You can do the measurements accurately. If you're a radiation oncologist, you will see where to do the margins will be done very easily if you have contrast. You can see the bony structures, the pleura, etc., the heart. What is important here is at the end of therapy, you can see there's still a residual mass, but the PET is become completely negative on these patients. So that's how it's a very important test. It allows us to assess response much earlier in these patients. This is a 15-year-old with non-small cell Hodgkin's lymphoma. Again, this is just brown fat activity, which is a variant. Younger patients tend to have lymphoid tissue, you can see here. The patients have breast activity, which you can see here. The PET CT scan, you still use the fusion image. Again, you can see this allows us to assess visually how much residual activity there is. The residual activity, if you look at it, is close to the background mediastinal blood pool. The mediastinal blood pool, obviously, this is where the heart is. The residual is very close, so that's a very good response. It's based on the Deauville criteria. Visual response, sorry, is this. At the end of our report, the bottom, the last statement, a lymphoma 5-point score, we used to call it the Deauville 5-point score, is 1, 2, 3, 4, or 5. If it's 1 and 2, 1 is it's no uptake above backgrounds like the lung. If it's 2, the uptake is equal to or less than the mediastinum. That's what you'd usually see, 1 or 2. Number 3, the uptake is greater than the mediastinum but less than the liver. So if you're not sure, you can do region of interest, get an SUV measurement, average. Don't look at the max, because the max is just the highest little tiny pixel. So you have to use the average if you're not that fluent yet. 4 and 5, it could be partial or stable disease or no response. If 4 and 5, it's hotter than the liver, the residual, or markedly hotter than the liver. But if the SUV measurements are lower than the baseline, they could be considered a partial response. But if they're higher, then it's progressive disease. Okay? You put an X if these are new areas of uptake unlikely related to the lymphoma. Usually these are inflammatory processes, right? If they get R-CHOP, R means Rituxan, R means inflammation because it's an antibody, you get an inflammatory response. You get these small nodes, they tend to be bilateral hilar, they tend to sometimes have small nodes in the axilla. The nodes on the CT scan are the clue. They have fatty hila, they have fat in the middle. So fat is your friend in the situation. So you see fat, they're usually pretty good site. So this is a Deauville 2, as I showed you. Thank God I was right on my slide. At the end of treatment, for us, 1 to 2 is CMR. 3 in clinical studies for Deauville 3 would be complete medical response. 4 or 5 is essentially a treatment failure if they don't go down. Okay. Interim evaluation, this is at the end of treatment. Interim, after 3 or 4 cycles, practically all our patients have a midway evaluation. Similar, 1 to 2 is CMR. If it's greater than 3, they might not go on the trial. If 4 or 5, if lower than baseline, is partial. Again, you have to do measurements if they're hotter than the liver to compare it. You just don't do this. You have to get buy-in from your referring physicians that this is what they want to do or go with. Okay? Because this eliminates the possibility. In the old days, we used to say it was a magnificent response. It was a great response. It's a complete response. What do they mean? But now if they have a score of 5, they know it's bad. They have a score of 1, fantastic. A score of 2, it's really good. 3, you make the passing grade, you're okay. But 4 or 5, you're in trouble. Okay? Is it good? This is our data from these are one of the few things which nuclear physicians and MD Anderson actually agree on, the visual criteria. They were blinded to the clinical information except for the PET study, 95% agreement, because it's visual. You look at the liver, if you look at enough PET scans, you know that the liver is fairly constant. And then you look at the mediastinum. You have to have good prep to minimize myocardial activity, low carbohydrate. No noodles, no buns, no cake, no candy, all of the good food. No ice cream, no rice, especially in our part of the world. They minimize that for a meal the evening before. You'll have less activity. You eat more meat for that night, or more protein-based, less. This is just another example. I like to show a few examples. Sometimes by looking at them, you get used to it. The younger patient, mixed cellularity Hodgkin's disease, has adenopathy, completed chemotherapy, and involved field radiation. This is for assessing recurrence. So they had what we call multimodality therapy. It's not unusual to see it. So when you look at it, the baseline, you already have the marrow, extranodal disease. And then when I look at them, I like to look at the Michael Jackson, the MIP. The younger people don't know who Michael Jackson is. He liked to spin around when he was done. The older people know who Michael Jackson is. He's dead. So you look at the MIP because it is good to see the true extent of the disease, particularly if you have esophageal, rectal, midline structures, involvement of the structures. If you have nodal disease which is heterogeneous, it's easier to see if you look at it from all angles. And here you can see brown fat activity. How I do remember brown fat, it's what people in Texas like to eat. They like to eat chicken wings and ribs. Ribs are moist and good because they have fat. You know, that's a brown fat. Chicken wings are good because they also have fat. Okay. But here you can see in a well-treated patient, you have uptake. That's recurrence. You suspect it. It's here in the marrow, and you can see in a nodule. And you have to not only see activity, you have to have an abnormally enlarged, anatomically accessible and anatomically visible. Because if it's, you can't say there's uptake there, but you can't see anything to correlate with it, don't say that. They'll get really upset. You know, what will they do with that information? So if you assess recurrence, you have to give them a suitable target to biopsy, because they need to validate the pathology with what they'll treat with. Or what they usually tell the patient, it's 50-50. You know, this guy Homer, he's pretty good, but he's not right all the time. He might have had an off day, he may have a jet lag, and he overcalled it. It could be inflammatory. A lot of the stuff we give now, the immunotherapies can cause inflammation. It is better to be safe than sorry. So you don't want to overtreat. So we still do pathology. This is just to show you how extensive it could be. The presentation already tells you. Do we have technologists in the audience? No? Well, your technologists are your front line. Our technologists are trained to take the history. The first thing they ask is point to us where the lymphoma is or was diagnosed. Or if they come to the clinic, they say, oh, I had it in my tibia right here. They know the extent of the scan. Oh, I was snoring. So you have to include the entire head. So your technologists have to be great at history taking. And they have to take the history before they inject, obviously. Well, otherwise, they'll have this high radiation exposure. It's not just the patient you worry about your staff. Okay, so our staff develops the protocol, and they actually give us notes on how the patient performed during the study. Did they move? Did they have hiccups? Did they suddenly have pain somewhere? You know, because they could be important. This is a different patient, supraclavicular mass. You can see, you know, it's so big you can't miss it. But I tried to show you that by looking at the CT component of the study, you can see what might be difficult to see on the PET study. You can see the kidneys. They don't look symmetric. You don't need to be an expert in anatomy to know that these kidneys are kind of big. They're enlarged. They have a very differing sites of attenuation. They have a rim of enhancement. Okay, you look at there's some central necrosis. Even the liver, the pancreas from here has heterogeneous areas of activity, of enhancement. So this is renal involvement. You can see it's renal involvement. Sometimes you don't pay attention to the kidneys as much. That's why I point this out. And the PET study will alert you to it. However, if you have normal excretion into the kidneys, you might not be thinking of it, as well as making sure you understand that you can see pancreatic involvement. Plain films are also important. You have to see, what I'm trying to say is, don't just use the PET study. If they have plain films, be curious, look at them. If they have CT scans, look at them from top to bottom. You'll become a very good CT reader, a body reader. Why? For us in radiology, you have to understand we're communists. I'm a communist. We share all the work because we get paid the same. I'm one of the few people who ask our radiologists to work for us, and they're happy to do it. And so what you realize, as nuclear medicine physicians, we are asked to read everything from pinealomas to I'm looking at Benjapa, neurofibromatosis with malignant degeneration, to any type of tumor. But our thoracic radiologists only want the lung cancers. Our abdominal radiologists want the GYN or liver tumors. We read everything. So you maintain the superiority by being able to read all tumor types. And lymphoma is a good prototype of that because it involves every organ, right? So this is a patient with hip pain, and for now on, it's MR. You have to know your MR. It's what CT was about 10 years ago. I try to tell people you gotta read the CT. MR is more sophisticated. It will take a lot more thought, time, and effort to be aware of it. This is a patient who has obviously a very large enhancing mass involving the soft tissues around the right hip. This patient has multi-organ involvement, and you can see here on the CT study, not only is there bone, but also soft tissue involvement. You can see here that there's involvement, low attenuation, as well as in the pancreas. You can see here the very large soft tissue mass, multi-level involvement. You can see here the soft tissue component. So this is extranodal disease. Why is this important? Radiation therapy, symptoms. Tomorrow we'll take a look at what do you call this? Fractures. You have to assess if the patients will be vulnerable to certain fractures. Do you have to radiate, or do you have to pin these patients? Patient with diffuse large B-cell therapy on recurrence follow-up, you have a whole body image. You can have multi-compartmental adenopathy, and you can see there's a spot beside the kidney. Non-contrast enhanced CT, you can see activity there. And on the contrast enhanced study, that's why we like contrast, you see this raised, it's like a crater upside down. And this is a site of recurrence. This is deep ulcer, heaped up margin, diffuse large B-cell lymphoma. Again, contrast, not just intravenous, but also oral contrast is important, particularly for directing a biopsy. That's very important. Why is this all important? If you use this criteria, this is from Sally Barrington and his group from England. Why is this important? For one thing, it allows us to publish in the New England Journal of Medicine. It allows you to assess whether a negative PET finding after only 3 cycles of ABVD chemotherapy in early stage Hodgkin's may require or not require consolidation radiotherapy. It actually didn't show positivity. It was very close, but not quite. The intent was to see if you just treat with 3 cycles of ABVD, it's enough, right? You don't need radiotherapy. Again, the trick, as I told you, these are risk-adapted adapted therapies. That is, if they respond well, you stop the treatment. If they don't respond, you switch the treatment. These are the type of studies being conducted. Again, none of the drug companies would ever sponsor this, because you have to understand the early treatments were phase 1 trials. You give treatment until the side effects kill the patient or they actually cause a lot of harm. You can't expect our drug companies to support studies which are designed to give less of the drug, you know? It's like you can't ask Coca-Cola to conduct a market survey if people will be satisfied with just 4 ounces of Coca-Cola instead of 16 ounces, you know? But actually, it's good stuff, because then it's less cost, more same effect, with less toxicity. The intent is actually very good. So this is what happens, like in a follicular lymphoma, 4 cycles of CHOP. You know, you don't have to be an expert. You know that it's still disease. RE-SHOP is still disease. Hyper-CVAD, metabolic response. You stick with that one. Okay, so these are the type of therapies which are done. The other types of therapies, and we're almost at the time, I told you about immunotherapy, but CART, they get the T cells from the patient, and they actually use them as a treatment. The CART cells, this is involvement of the bowel with lymphoma. They reinfuse the cells which they harvested, anti-CD19 CART cells, and reinfuse them into the patient to allow them to get a response to treatment. So the Lugano classification is again based on FDG PET CT studies. My advice is to give it with contrast so you have the whole assessment there. Our studies, when we design the CT component of the study, it's not a full blast CT. It's with the help of our radiologists and our medical physicists. It actually is tailored so that the dose is sufficient to be similar to a diagnostic CT scan. Despite that, we still discourage surveillance study. They come in, it's like an oil change. You do the oil change, but you don't do the scan unless there's something going on with the patient. They have B symptoms, there's a new palpable lymph node, or something was detected. So you have to be judicious in their use of your follow-up scans because of the extra radiation dose. We actually keep track of how much radiations our patients get. It's part of their medical record, and every time they get a dose, we tally how much radiation you get. The most radiation phobic people are nuclear medicine people usually, and radiologists, because we know what it does. So the least amount, it's a Lara principle, as low as reasonably achievable to get what you need to do. So you have to do this not in isolation, but with input from your referring physician. If they want to do the Lugano criteria, it has to come from them, or you have to have a dialogue with them. It gives you standardized staging and response evaluation. We do the imaging up front to assess if they're variable or not, or they have nothing. We use CT. If there is FDG uptake, we try to give contrast so you still get the advantages of the CT. For us, being a cancer center, we don't just do baseline and end of therapy, but we usually do response evaluation in the interim after 2, 3, or 4 cycles of therapy. Because most of them belong to trials where they can adjust the treatment based on possibility of negativity. You know the patterns of spread. It spreads to every organ. If it's nodal or extranodal or both, because they have implications. Why? The implications are usually for radiation therapy, which organ is involved or not. Hybrid imaging is the standard. I show you examples where you can guide biopsy up front or at the time of recurrence. At the time of recurrence, if it's in the other side of the body, you have to see, or if it's extranodal, you have to biopsy. Contrast enhanced CT is still very important for non-FDG avid lymphoma. Standardized reporting is encouraged. If you go to the American College of Radiology, they have templates for everything, including nuclear medicine. We contribute to this. Our radiologists are our friends. They're not our enemies. Our enemies is the cancer. So, but there are, for every nuclear medicine physician in the US, 12 radiologists. So instead of competing with them, we work with them. So you have the standardized templates. So the nomenclature in the description is the same. It's RADLEX. It's the lexicon for radiology. Okay? Because the standards of people like me who are pure nuclear are not the norm anymore in the US. Most people we have are dual or triple boarded. The latest iteration we have are medical oncologists trained as nuclear physicians, because they are the ones who appreciate the value of molecular imaging with precision therapy to try to design the imaging agents to assess the targets or drugs they have. So it's not just radiologists. Medical oncologists are in on this game. Other tracers, just very quickly, I try to focus on FDGs actually there, but this is a study we did with Stanford and Iowa, and one more place, I'm blanking out, and one group in Germany. where we did fluorothymidine. Fluorothymidine again goes. It's an analog for thymidine. The minor pathway. It goes to the cells which are actively proliferating, or an S phase. So fluorothymidine you can easily see as having a lot of marrow activity. You can see here, this is the baseline FDG study, right? And then after therapy, you can see there's really no activity left in the very large mass in the pelvis, but you can see residual activity in the primary mass on the FDG study. You may call this 4, right? And then at follow-up, it goes away. So it's more sensitive, sometimes more accurate. This is for interim imaging. We try to use the FLT to assess interim specificity because a lot of times these patients get immunotherapies or cause an inflammatory response. You can see here residual in fluorothymidine. This is glucose, fluorothymidine. You have a lot of marrow, a lot of liver. You can see residual FLT activity. When you biopsy this was residual FDG avid disease, not inflammation. Okay, so that's where I'd like to stop. And I think we take questions in 5 minutes for any questions. Yes, sir. I'm sorry, can you repeat it? Yes, sir. The X. We don't call, we only call it if it's questionable and we can decide if it's inflammation or not. If it's inflammation, like they're young patients, we call it as such. If we call it X, is if we can't decide. It's like when you have a VQ scan and you have an indeterminate study, it's an X. You can't decide if it's lymphoma or inflammation, we call it an X. So the activity may not relate to lymphoma. What are examples? If you give them immunotherapy, they could have increased activity in the thyroid, in the pituitary. They can have focal activity in the bowel, because sometimes you have bowel lymphoma. You can have focal myositis. So these are X things. Is that better? Yes.
So we don't report those in our DBC report those articles?
What do you mean? Do we report them?
Yeah. Like for example, tonsils, we know there's a physiological range.
Yeah. If they're physiologic range, we don't see them. Unless they have had a baseline study where there was lymphoid tissue involvement. I mentioned that because sometimes, let's say they have involvement of the right tonsil, and then they would tend to consolidate that with radiation therapy. What happens is the left tonsil becomes very prominent, and then we say the left tonsil is normal. It becomes more prominent because of post-radiation effect on the right tonsil. But we don't put that as an X because we know it's there. However, if the right tonsil was radiated and then the scan was done very short interval after radiation, there's activity in the known right tonsil involvement of lymphoma. We may call it an X if the activity is just as hot as the other side, where we'd expect it to be less, because that is unusual. If it's unusual, or we can decide, we rarely put an X, actually. The X is, we try to avoid. X means you're really not that sure. We really rarely do that, the X, for us, at least in an experienced group. Thank you. I think you have a question, sir. Yes, sir. We have one also.
In your hospital, do all the lymphoma patients perform the SCT as a screening tool of the basal disease?
That's what? I'm sorry?
All the patients perform the SCT, FDG SCT,
Yeah. As a first, yes.
After that, they change the city or choose the
Oh, it's always FDG.
always
It's FDG.
even though the lower FDG.
If they have low FDG uptake, we still do it. If they have no FDG activity at all, we might stop it. And then let me just qualify that. If they have no FDG activity, they use the CT. But if there is progression or any sign of non-response on the CT, they ask for a PET again because they're aware of the transformation.
It's another private question. So your country covers insurance covers the lymphoma.
Yeah. Yes, because again, they can't tell unless they scan. If lymphoma is covered for up to 4 scans. All lymphomas, they don't specify low grade, high grade. As long as you have lymphoma up to, the problem is they limit it up to 4. Much of my gray hair comes from going to our local Medicare to appeal for patients who have recurrence. So the money is saved actually by actually making sure, like the other patient, had they treated them for low grade with observation, patient may die from that. So it saves money. So you need to do non-FDG if they have no uptake with contrast. Once they don't seem to be responding or they have actual progression on the CT, they usually ask for a PET study because it may be transformation. And it's the knowledge. A lot of this has got to do with educating the physicians. But we're unique because our people were like our lymphoma doc, the former chief was Fernando Cabanillas. He was a very long proponent of gallium imaging. This was like in the 70s and 80s. When PET happened, he was beside himself because he could actually see it. Gallium, you needed an expert. So that's where it is. You have another question, sir? Please. I'm sorry he was ahead. I'm sorry you don't see him, but
In radiation oncology, we use PET CT for planning system, for planning to fuse with our CT in order to delineate the tumor. So we use the same setup that we use in our couch.
yes, CT sim.
Yes. Does it make any difference to you to read the
Yeah. If you're going to use it for, the question is if you're going to use it for radiation therapy planning. One of the first things I did with Anderson was to first 4 scanners. One of them was actually put in radiation therapy. James Cox was very nice. He was the former radiation oncology head. I always ally myself with the 3 people. The people who know, who are very decisive, the surgeons. Where they're in doubt, they'll take it out. Lung cancer. The people who actually can cure people. Radiation oncology and medical oncology in lymphoma. So if they're going to do radiation therapy planning, we use the flat bed and the restraint system. If they're head and neck, there have to be the arms down with the you put them on the vacuum lock if you want to use them for therapy. If you're going to use the baseline study for treatment planning, I don't think it makes that much of a difference because if you do it with the diagnostic study, you can actually do the contouring very easily. I think it becomes an issue for us to use the vac lock and the restraint system if it's for thoracic tumors because we have to gate them. For liver tumors or esophageal, upper esophageal tumors because of the movement. For head and neck, it's more for precision of the margin delineation. Well, this is a more refined question. This is trying to refine your acquisition based on radiation oncology. What we also use is I have no stocks in any of the imaging companies, but including also the software is very important. It might be important to consider a unified software system. We use MIM, MIMVista, because it's quite easily adaptable for rad-onc because they actually do treatment planning for rad-onc, and it's friendly to nuclear medicine techniques. Sir,
Sorry, it's the last question.
Sorry, I'll be here for at least another 10 days. You'll be tired of me later on. You even know where I live, so but I'm married. That's all I say.
organ classification usable for any age, especially for children?
Oh, the FDG for any age, yes. I've done it in like newborn, the FDG study, and people in their 90s. Nowadays, even 70s or 80s, people, if yours, the insurance, if you retire at 68 or 69, they say you should have enough money to last you up to almost 90 years old. So it is a very good test. What we tell our patients, if you do a low-dose CT with FDG, it is 40% of the radiation you will get from a diagnostic CT scan of the chest, abdomen, and pelvis. So it's actually a much lower dose, particularly for lymphoma, much more effective imaging technique because you identify small volume disease, and you can actually exclude disease. Sometimes what they think is lymphoma is not lymphoma. So that's why, yes, it is safe for children.
Thank you.
And I have to make one more point. We have a special setup for, at least for us, in the younger children in our effort to minimize anesthesia. So we have a setup where we have a PET scanner and a teddy bear. I'm sorry I didn't think I'd show it. But the teddy bear, we ask the children, these younger children, about 5, 6, 7, who can understand. They have a butterfly, they put the butterfly on the teddy bear, and they make the teddy bear lie back, and the light goes in, and the scanner goes in and out. And then when they get scanned, they hold the teddy bear. And if they get scanned without moving, they get to keep the teddy bear, and we give them a bigger one. So it's an educational tool. We won first prize for that. Why? Because the anesthesiologist didn't like coming down to nuclear medicine because it's radioactive, they said. But that education for the children, what I've noticed are the children we deal with are actually very mature for their age. They mature very quickly because I think they realize what's happening, etc. I worry more about the patient's parents. They look distraught. The weight of the world is on them. We do more work reassuring the parents and the family. The child just wants to get out and eat afterwards and play. But thank you very much.
Thank you very much. We have coffee break here.